Welcome back to the deep dive. We're about to jump into a topic today that's, well, it's rare, but it carries some really significant weight, especially if you're prepping for exams like the MSRA.
Hmm.
We're talking about Peutz-Jeghers Syndrome.
TJS.
Our goal today is basically to cut through the noise, pull out the high-yield stuff you absolutely need to know. Think of this as your, focused deep dive into PJS, designed to make the key info stick.
Exactly. Peutz-Jeghers is one of those conditions that, yeah, it's uncommon, but it has such distinct features
Yeah.
and really important associations, particularly that link to various cancers, that it's just crucial to recognize.
Right.
So we'll cover the basics, what causes it, how it looks, and importantly, how it's managed, all based on the kind of essential revision material you'd focus on.
Okay, let's dive right in then. When you hear Peutz-Jeghers syndrome, what are the two absolute headline features?
Yeah, the absolute defining things are, one, these specific hamartomatous polyps. You find them throughout the GI tract.
Polyp.
And two, equally distinctive hyperpigmented spots, typically around the lips, inside the mouth, the oral mucosa, and sometimes the perianal area too.
Got it. Spots and polyps. And it's a genetic thing, isn't it? So, where does it start at the DNA level?
Yeah, it's primarily down to mutations in one specific gene called STK11.
STK11.
You might also see it called LKB1. It lives on chromosome 19p13.3 specifically, and its job is basically regulating cell growth. So when it's mutated, that regulation goes wrong.
Huh. So the single gene fault, it causes both the gut polyps and these bunny spots. Seems kind of disparate.
It does, doesn't it?
Yeah.
But it's fascinating. The mutation disrupts pathways that control cell growth and sort of organization in the gut. That leads to these hamartomatous polyps. They're benign growths, but a bit jumbled tissue-wise.
Okay.
And separately, it seems the mutation also affects melanin production in those specific areas, causing the dark spots.
Okay, so STK11 mutation is the culprit. How does someone actually get this mutation? Is it always inherited?
Well, it is inherited in an autosomal dominant way. So if a parent has it, there's a 50-50 chance for each child.
Right, 50%.
But, and this is really important, it's not always inherited. About half of cases are thought to be de novo, a brand new mutation happening in that individual for the first time.
Ah, okay. So if I'm thinking risk factors, family history is huge, but it's not the only way.
Exactly. Number one risk factor, family history, definitely. If a first-degree relative has PJS, the risk is much higher. But beyond that, there aren't really any known environmental or lifestyle factors that play a role.
Right. So a little memory hook then? See the spots and polyps, think family history first.
Perfect. And, just to quickly check, say a 10-year-old comes in with recurrent tummy aches, and you notice those odd dark freckles around their mouth.
Yeah.
What's the vital history question?
You've absolutely got to ask about family history. Any similar problems, anyone diagnosed with PJS? Because that's part of the actual diagnostic criteria, isn't it? Okay, we touched on how the mutation causes trouble, STK11, as that growth regulator. Can we just sort of nail down the pathophysiology a bit more?
Sure. So STK11 normally acts like a brake on cell growth, a tumor suppressor. When it's mutated, the brake, well, it doesn't work properly.
So cells just keep dividing.
In the gut lining, yeah, that's the effect. You get this overgrowth, but it's disorganized. It's a mix of normal tissue components, smooth muscle, connective tissue, the lining cells forming those hamartomas.
Okay. And the spots again?
The spots are separate. They're not cancerous or anything. It's just an increase in melanocytes, pigment cells, and more melanin being produced right there in the basal layer of the skin or mucosa in those specific spots.
Now, PJS is rare, but there are other things that cause polyps, right? Especially in younger people. What else needs to be on the differential diagnosis list?
Absolutely.
Yeah.
If you see polyps, you need to think broader. The main ones to differentiate from PJS are other genetic polyposis syndromes, primarily familial adenomatous polyposis, FAP.
FAP.
Okay. And the juvenile polyposis syndrome, JPS.
Yep.
FAP gives you thousands of adenomatous polyps, mainly colon, huge cancer risk.
Yeah.
JPS involves juvenile polyps, also increased cancer risk.
So the type of polyp is key.
Hugely important. The histology tells you. Hamartoma and PJS, adenoma and FAP, juvenile polyp and JPS, often needs genetic testing too, to be sure.
And just how rare are we talking? What are the numbers like for PJS?
Well, the estimates do vary quite a bit worldwide, somewhere between, say, 1 in 25,000 people, maybe up to 1 in 300,000. It's hard to pin down exactly.
Wow, quite a range.
Yeah, and specific UK prevalence isn't stated as clearly known, but it hits all ethnicities and males and females equally.
Okay, let's shift gears. Moving from the science bit to what you'd actually see clinically, what are the classic signs and symptoms we should be looking out for?
Right, so back to those two core features, the GI hamartomatous polyps and the mucocutaneous pigmentation.
Spots.
Yeah, the spots, dark brown, blackish, freckle-like. Lips are classic, inside the cheeks, the buccal mucosa around the nose, hands, feet, and the perianal or genital areas.
Okay.
And a useful clinical point, the skin spots often fade a bit after puberty, but the ones inside the mouth,
Yeah.
they tend to stick around. So always check the buccal mucosa, even in adults.
That's a good tip. And the polyps themselves, what problems do they cause?
Oh, they can cause major issues. They can grow pretty big, anywhere from the stomach down. So common symptoms are recurrent abdominal pain, often crampy.
Colicky.
Yeah, colicky pain.
Oh.
And GI bleeding. That might be obvious blood, hematochezia, or it could be slower, leading to iron deficiency anemia.
Okay.
But the really critical one, in about half the cases, the first time someone presents, is with an acute bowel obstruction.
Wow, half.
Yeah. And often that's caused by intussusception, where a polyp drags the bowel into itself like a telescope. It's a surgical emergency.
Right, needs sorting out fast.
Definitely. Other things, less common, maybe rectal prolapse. In girls, sometimes precocious puberty due to certain associated tumors. And remember, polyps can pop up elsewhere too. Nose, airways, biliary tract, even uterus or bladder.
Okay, so you see the pigmentation, maybe there's a history of pain or bleeding. How do you actually formally diagnose PJS? Are there, like, official criteria?
Yes, there are. The WHO criteria are generally used. You only need to meet one of these to clinch the clinical diagnosis. Number one, 3 or more PJS polyps confirmed on histology.
Okay, 3 polyps.
Or number 2, any number of PJS polyps if there's also a family history of PJS.
Right, polyps plus family history.
Or number 3, just the characteristic pigmentation if there's also a family history.
Pigmentation plus family history, got it. Let's try a quick scenario. 18-year-old admitted bad abdominal pain. Scan shows multiple large polyps in the small bowel, look like hamartomas. You examine them, notice subtle dark spots on their lips. Diagnosis, next step.
Okay, well, hamartomas plus the lip spots. PJS is jumping right to the top of the list. Very likely. The next definitive step, genetic testing for that STK11 mutation. That confirms it.
Right. So investigations confirm it. Then what? How do you manage someone with PJS long term? Sounds like it needs quite a bit of follow-up.
Oh, absolutely. It's definitely not a diagnose and discharges situation. It needs a proper multidisciplinary team. You need your gastroenterologists, geneticists, surgeons, maybe oncologists, gynecologists, depending on the risks.
And what's the main sort of philosophy behind the management?
It's all about intensive surveillance and getting those polyps out proactively.
Why? 2 main reasons.
Exactly. 1, prevent the acute stuff, obstruction, bleeding. 2, significantly reduce that lifelong cancer risk that comes with PJS.
Lots of scoops.
Lots of scopes, regular upper endoscopy,
Yeah.
colonoscopy, and often capsule endoscopy to get a good look at the small bowel, which is tricky to reach otherwise.
Right, the camera pill.
Yeah. And when they find polyps that are big enough for causing symptoms, they're removed, usually endoscopically. Sometimes needs fancier techniques like double balloon enteroscopy for difficult ones, or even surgery if they're really large or complex.
Is there a set schedule for the screening, like ages and frequencies?
Yeah, there are guidelines. Surveillance typically starts young, around age 12, with upper endoscopy and colonoscopy.
Age 12. Okay.
And then specifically for colorectal cancer surveillance, it's colonoscopy every 2 years from age 25.
Every 2 years from 25.
And that's just the gut. Because of the risk of other cancers, screening protocols often include regular MRIs, maybe ultrasound, breast exams, testicular exams, smear tests. It depends on the specific protocol and the patient's age and sex.
Wow, that's comprehensive.
It has to be. And genetic counseling is vital too, not just for the patient, but for their family siblings. Kids to talk about testing if the mutation is known.
Makes sense. What about the spots? Can you treat those if they bother someone?
Yes, if the pigmentation is a real cosmetic issue, laser or light therapy can sometimes be used to lighten them.
Okay. And is there, like, a magic pill, anything to stop the polyps growing?
Unfortunately, no. There's currently no drug, no pharmacological prophylaxis that can stop the polyps forming. It really is all about surveillance, removal, and screening.
Right. Okay, another quick scenario. A 35-year-old man just diagnosed with PJS genetically after an intussusception. What are the key management things you're talking about with him right now?
Okay, 35-year-old male. Top of the list is explaining the need for regular colonoscopies. He's over 25, so that's every 2 years.
Okay.
Then discussing upper GI and probably small bowel surveillance too. And definitely the screening for other cancers, testicular self-exams are crucial, potentially discussing pancreatic screening depending on guidelines, and of course genetic counseling for him and potentially his family members.
And the main message is why you're doing all this.
Absolutely. It's all about managing and mitigating that significantly increased lifelong risk of various cancers.
So, looking down the road, what does a PJS diagnosis mean for someone's future? What's the general outlook, the prognosis?
It really varies. It depends a lot on how aggressively the polyps grow and critically whether associated cancers develop.
But the surveillance helps.
Massively. The good news is, with proper surveillance and proactive management, getting those polyps out, the outcomes are much, much better than they would be otherwise. It definitely reduces complications and lowers the cancer risk significantly compared to doing nothing.
But it's lifelong.
It is lifelong. It's constant vigilance because that elevated cancer risk across multiple organs doesn't just go away. It's something they live with.
Okay, and finally, just to recap, what are the main complications, the big problems we're trying to head off with all this management?
Well, the immediate acute things are usually intestinal obstruction, often from intussusception.
Right, the telescoping bowel.
Exactly. And gastrointestinal bleeding, which can be anything from slow oozing causing anemia to a major bleed.
And the long-term worry.
The big one long-term is cancer. Significantly higher risk of GI cancers, stomach, small bowel especially, colon, but also outside the gut. Breast cancer, ovarian, pancreatic, lung, testicular. It's quite a list.
And you mentioned the number of polyps relating to colon cancer risk.
Yeah, that's noted. More polyps seem to correlate with a higher risk of colon cancer specifically, which really underscores why getting them removed via surveillance is so critical.
Wow. Okay, that was a really thorough run-through of Peutz-Jeghers Syndrome. It's pretty amazing, isn't it, how one faulty gene can cause such distinct things: skin spots, bowel polyps, obstruction risk, and this broad increase in cancer risk.
It absolutely is. And understanding that link, the genetics, recognizing the key features, the pigmentation pattern, the hamartomas, and crucially, appreciating why that intensive lifelong surveillance is needed. That's vital stuff for exams like the MSRA and for looking after patients.
Yeah. So for you listening, hopefully this deep dive has really hammered home those core concepts and given you a clear way to think about PJS when you encounter it in questions or, potentially in clinical practice down the line.
Maybe a final thought. Just consider how that single genetic flaw cascades into such diverse problems, from something seemingly minor like freckles to life-threatening cancers affecting multiple organ systems. It really forces you to think about the long-term management challenge, balancing aggressive surveillance and intervention against the potential harms, all across a patient's entire lifespan. It's a real balancing act in preventive medicine.
That is a lot to think about, a really powerful point to end on. We've covered a huge amount of essential ground today. For more free MSRA revision resources, visit freemsra.com, and for the full premium revision toolkit, head to passthemsra.com.